about mediastinoscopy and whether it's redundant in mediastinal staging. And my answer is no, and a resounding one at that. So in the next 8 minutes, I'm going to try to convince you that it's very important. So what are we not debating today? Whether it's rigorous staging is required. Of course, that question has been answered earlier. We are also not going to discuss the options of treatment, as in everyone's thought about it, and probably it's a topic for another day. So when do we say something is redundant? That's when you usually have an alternate option. And the alternate option has to be more effective, or at least as accurate as the current one. It should be easy to adopt and replicable. It should have less complications, or should be less complicated. It should be more convenient, and if possible, cheaper. So the challenger, that's a newer option, should be better in at least most of these criteria to overthrow the king or the current option, which is the standard. What's the current standard? Video-assisted mediastinoscopy or lymphadenectomy is the current gold standard. And if you look at this chart of a few series which have been reported, you can see that the negative predictive value in assessing the mediastinum is from between 97 to 100%. That's almost impossible to beat. Now let's take a close look at the challenger, that's EBUS. And it's exactly the same paper which Prashant quoted, Yasufuku. Excellent results, 81 and 91% negative predictive value. And the latest one from South Korea, which also showed a very good negative predictive value and sensitivity. Actually, when you look at it, in the mediastinoscopy arm of the South Korean trial, the EBUS actually did much better. So is the challenger ready to beat the king? Let's take a closer look. This is the South Korean trial again. And if you look at it, traditional mediastinoscopy was used in 1/3 of the patient. That's not even the standard. And if you look at the lymph node station sample and the median number of lymph nodes sampled, it's 3. That's not great. So overall, when you do such a mediastinoscopy, the results are obviously not great. You get a negative predictive value of 78% and a sensitivity of 81%, which is inferior to EBUS in their study, and not even comparable to the results which Marcin has achieved here, 96% and 98% with Temla. And similar results are possible with Vamla as well. So you may say that there's an unfair comparison across different studies and that's a very unfair comparison actually. So let's look at the randomized data. There are actually 2 randomized studies which have come up, which actually looked at the non-inferiority or equivalence of EBUS against mediastinoscopy. Unfortunately, EBUS didn't do well. Their studies, the conclusion said the addition of surgical staging improved sensitivity, and mediastinoscopy has to be done, like Dr. Amipota said, in every EUS and EBUS negative patient. So to finally answer the question, is EBUS more accurate than mediastinoscopy? The answer is a no. What about replicability? If you look at most of the series which Prashant has shown, most of them have come from single institutions, massive experience. Even the South Korean series, they required, minimum requirement was 300 cases experience. That's difficult to achieve in India. Most of these patients, although Prashant said deep sedation, it's a euphemism for general anesthesia. It's as close as you can get to general anesthesia without a tube in the trachea. Why do they need such thing? It's because if we look at this from a recent meta-analysis, actually, most of these series, including Yasufuku, use GA, 7 out of 13 series. Why? Because they targeted very small lymph nodes, as can be seen here, 5 mm or more. And they took 3 to 5 passes per node, and they had rapid on-site evaluation. If you do all this, then you can get equivalent results, and this is not a simple procedure. So if you think we can get an EBUS score and actually replicate this, not very easy. So replicability, no. Complications, wow, that's one place where EBUS wins over Vamla. Vamla has reduced the number of complications, but still recurrent laryngeal nerve palsy of 2.5% is something to worry about. What about convenience? Prashant pushed EBUS, and it's true, it's a daycare procedure with quote unquote deep sedation and is a separate event from surgery. Whereas Vamla is a single anesthesia, it requires GA, but you can club it with surgery. So it could be potentially an advantage, especially in today's era where you're looking at COVID and you want to reduce the number of visits from the patient to the hospital. So probably this is where you should go. But it's open for debate. I would leave it to you. The final one is the cost. EBUS, the cost of buying a scope like this with the paraphernalia is rupees 1.5 crores. Each procedure will cost you in terms of consumables at least rupees 20,000. And if you want an on-site pathologist, wow, expensive. What about VAMLA? The equipment cost is between 20 to 25 lakhs. Consumables, I don't use any, probably some Surgicel or hemostatic agent. And frozen section, most of us operate in cancer centers, so it's always there. So what are we comparing? VAMLA is cheaper, no questions about it. So let's go back to the original question. Is mediastinoscopy redundant? I would rephrase it and ask, is EBUS ready to replace mediastinoscopy? For that, it would have to be good in at least some of these 5 criteria. Let's go there. Is EBUS more accurate? My answer is no, not great evidence. Is it replicable or easy to adopt to achieve similarly good results? Nah. Complications, I give up. EBUS has much less complications. Is it convenient? Open to debate. You decide. Cheaper? Definitely no. So overall, out of the 5 criteria, it's lost outright in 3, and definitely it's 1 and 1. So when I come to the final question, is mediastinoscopy redundant? My answer is not by a long, long way. So thank you very much for this opportunity for